Welcome everyone to this webinar. I appreciate your patience as we have solved a few technical issues. Today we will be talking about research for SBC programming during a public health emergency response, and we'll be doing so using the recent Zika epidemic in the Americas as an example. My name is Martha Silva, and my role in this project, Breakthrough Research Project, is the Data Strategist and Innovation Team Lead. To start with, I want to introduce our project to those of you who may not know us yet. Breakthrough Research is a 5-year USAID funded project that fosters social and behavior change, which we refer to as SBC, by conducting cutting-edge research and evaluation and promoting evidence-based solutions to improve health and development programs worldwide. Breakthrough Research works closely with Breakthrough Action, our sister project, led by Johns Hopkins University Center for Communication Programs. And some of the work that we will describe today has been conducted in partnership with Breakthrough Action, so I wanted to acknowledge this collaboration from the start. Lastly, Breakthrough Research is a consortium of 6 different partners led by Population Council. I myself, as I said, represent Tulane University, who is part of this consortium, together with Avenir Health, Institutes for Reproductive Health, Ideas 42, and Population Reference Bureau. Today's webinar, I'm very happy to share this space with 3 other colleagues. First off, we're very pleased to have Arianna Serino join us here for this webinar. Arianna is a social behavior change technical advisor for USAID and has worked closely with us as SBC partners in the USAID Zika response. And she will start us off discussing the role of SBC in public health emergency. And then Jessie Pinchoff from Population Council will follow, describing an example of how research and evidence can help inform what prevention behaviors to target in a public health emergency response. After Jessie, Kate Spielman, also from Population Council, will describe an example of how research can help identify behavioral drivers and contribute towards course correction of community-level activities. I will then close off the webinar with a final section capturing lessons learned for future responses. And we will end this webinar with an opportunity for Q&A and hopefully some discussion. This webinar was designed to give you the highlights of what has been our Zika research portfolio over the last 2.5 years, with a focus on how research can support SBC programming in public health emergencies. There are some key takeaways from this webinar that we wanted to share up front with you. By the end of the webinar, we will hopefully show that prioritizing prevention behaviors through an evidence-driven process leads to more harmonized SBC programming in a public health emergency response. We will also hopefully show you how data can help SBC programs course correct through a response by showing you an example of secondary data analysis, assessing home visits associations with preventive vector control behaviors. The final takeaway will be around the importance of coordination within a public health emergency response when it comes to research as well, and also using rapid research techniques and balancing speed versus rigor. So now I will hand it over to Arianna to talk about SBC in public health emergencies.
Hello, everyone. Good morning. So USAID has continued to support countries in their preparedness and response efforts over the last 15 years or so for infectious disease outbreaks such as H1N1, Ebola, most recently Zika. SBC programming is very important in outbreak responses because when you don't have treatment, all you have is human behavior for prevention. And when you do have a treatment, you need social and behavior change interventions to ensure uptake of that treatment. So human behavior and understanding what influences it is an important part at all stages of an outbreak response. We need communities to participate in surveillance and reporting cases. We need people's behaviors to change to contain transmission. And we need communities to trust and collaborate with first-line responders. So what are some of the things that we need to know in order to plan SBC programming during an emergency response? Well, some of the key questions are: how is the disease transmitted? Who is affected? Similarities in transmission to other diseases that we already know. Is there an existing evidence base that can be adapted? What behaviors do we promote to prevent that transmission? What drives these behaviors? And how do we ensure that we are learning and documenting in the process? So now a brief overview of the USAID Zika response. So the response to Zika in Latin America and the Caribbean started in April of 2016 and ended this past September, covering 23 countries in the region. The goal of the program has been to minimize adverse pregnancy outcomes due to Zika. And the program supported governments in responding to the Zika outbreak through 4 lines of effort: social and behavior change, vector control, service delivery, research and innovation, and community engagement as a cross-cutting line of effort. So why is behavior prioritization needed? Just to give you a bit of context, when Zika cases were detected in Latin America, we were still continuing to learn about new modes of transmission, such as sexual transmission, as well as the different health consequences of the Zika virus, such as the range of congenital delays that it causes in babies when mothers are infected during pregnancy. So partners in the field began to implement programming for behavior change as the evidence around the actual disease continued to evolve. At the close of the first year of programming, through a rapid review of implementing partner materials, we counted around 30 Zika prevention behaviors being promoted across countries and partners. So it was clear at that point that implementing partners and the program was not speaking with one voice. Now, why did we think that was a problem from an SBC programming perspective? So there are several reasons why promoting more behaviors is not necessarily better. Some of these reasons are individual and some are programmatic. So on the individual level, we have cognitive overload, which is a situation where too much information or too many tasks are given to a learner simultaneously, and this results in the learner being unable to process all this information. So in cognitive psychology, cognitive load refers to the used amount of working memory resources. So as human beings, we only have a limited capability to retain information. Secondly, behavioral intentions. Research shows that individuals who are asked to perform too many behaviors may be less likely to change any behavior at all. And that is because they may experience difficulty called choice conflict, which is choosing which behaviors to adopt within the large range of behaviors presented. So on a programmatic level, we know that harmonizing and speaking with one voice is more effective. We know from evidence, from behavioral science, social marketing, human-centered design, and other areas of research, that promoting clear messages around a short list of behaviors consistently, concisely, specifically, and repeatedly actually improves behavioral uptake. So harmonizing efforts among implementing partners leads to greater effectiveness of SBC programming. I will now pass it over to my colleague Jessie, who will talk about the process we undertook to actually prioritize Zika prevention behaviors.
Hi. So to solve this problem of the lack of harmonization, we developed and implemented a prioritization process for situations such as this, or really any, to aid in the planning of an SBC program. So we first identified stakeholders, and this process was led by the prioritization team, which was USAID, Breakthrough Action, and Breakthrough Research. Our stakeholders included members of the USAID Zika SBC working group that was comprised of implementing partners and a diverse range of technical experts that were in the field responding to Zika. Our objective was to identify a short list of behaviors with the highest potential to prevent Zika transmission and negative pregnancy outcomes based on existing evidence and our experience in the field to target our priority audiences, which were pregnant women, their partners, and those who influenced them. So of the over 30 variations of behaviors that were out there, we grouped together similar behaviors. We reduced according to any limitations or any known ineffective behaviors, and we came up with 13 candidate behaviors. So next, we needed to decide what criteria to use to assess these 13 candidate behaviors. So this is an image of our final criteria. This was facilitated by a consensus building process led by our partner, Breakthrough Action. We decided on these first two criteria that would glean from available evidence. So to determine how effective behaviors were for reducing Zika transmission and negative pregnancy outcomes, and also at what scale. And these first two are based on peer-reviewed manuscripts, published reports, papers, and other available evidence. The third criteria, amenable to change, was based on 3 subcomponents to determine how likely the behavior was to actually be put into practice. So this was comprised of, how frequently do you need to carry out the behavior? Is it feasible for someone to carry out this behavior? Does it require negotiation with other people, or could you carry it out alone? And then third, is it easy to access any required materials for the behavior? So if any was prohibitively expensive or something, we would take that into account. We can link to the full prioritization documentation. I think we have a link later in this presentation, and we also have a paper on this process published in Global Health Science and Practice, and we can share that as well. So now we have our 13 candidate behaviors, and we have agreed on a set of criteria. So the next step was to conduct an evidence review to determine what was already published or reported on regarding evidence to prevent transmission, and then summarize our findings. I'll give a little bit more information on the evidence review in my next slide. After the evidence was compiled, each behavior was run through our criteria from the previous slide, and the final behaviors were selected. And an important note is that these steps were designed to be flexible to account for situations where we didn't have all of the information or where we had to adapt based on the needs of our partners or any realities on the ground. So it's not as formal as these slides make it out to be, but we tried to create a process that could be replicated. So for the evidence review, we were looking for different types of publications with attention to the level of rigor of the methodology used to determine what behaviors were most effective for Zika prevention. However, there was very little published about Zika, especially for this region, because it had never been there before. So we had to learn from evidence regarding other diseases with similar modes of transmission. Arboviruses such as dengue and chikungunya are transmitted by the same mosquito as Zika. And there's a lot of evidence available regarding Aedes aegypti mosquitoes that we were able to adapt and learn from. But an added challenge was that unlike dengue or chikungunya, Zika is sexually transmitted. So we also assessed research on other sexually transmitted infections and what works, for example, promoting condom use. But for sexual transmission, there were really no perfect parallels. And we adapted information as best we could from Aedes-borne arboviruses and from STI HIV literature. And we did have to get a bit creative, sometimes seeking information in conference proceedings or even having phone calls with experts who were conducting ongoing field research in order to gather the evidence as best we could. Some challenges included the lack of available research on sexual transmission of Zika, and from within the literature, we sometimes found that there was not enough detail on how exactly the behaviors were carried out. And sometimes behaviors were packaged together in an evaluation, so it was difficult to determine if one behavior was effective or if it really had to be the whole package of interventions. So we started to develop this process in November of 2017. We refined the criteria and list of behaviors across multiple Zika SBC working group meetings where we sought feedback and refined our behaviors and criteria. We had the opportunity to contextualize the process and behaviors in a few countries to beta test. And then by May 2018, we had reached a consensus and disseminated our findings broadly. So based on the prioritization results, which are documented in these first two images on the left, from these, Breakthrough Action developed many important materials and products, including a technical specification guide for the prioritized behaviors. That's the second document here. And from these, Breakthrough Action also developed job aids, curricula, and other tools that have been disseminated across the countries and with all of the partners. And other USAID Zika partners were also able to adapt their programming based on the guidance from the prioritization. So here is one example of one of our prioritized behaviors, the application of mosquito repellent using each product as directed for the duration of pregnancy to reduce risk of Zika transmission through mosquito bites. And then this is an image of some material that was developed to promote that behavior. So our goal was to develop a process to address the issue of implementing partners not speaking with one voice. The concern was that the impact of the SBC programming was diminished because there were too many messages creating confusion, as Arianna described. So this flexible collaborative process helps to prioritize prevention behaviors, building on available evidence, and this led to a more harmonized SBC program and highlights the importance of prioritization for effective SBC programming. And then through our documentation of lessons learned, we collected implementing partner perceptions of how the prioritization impacted their programming. So one of the many ways was that community volunteers were able to simplify their work by focusing on fewer messages with more time to spend on the details. The process of developing and validating these behaviors also made volunteers more confident in what they were promoting because they understood the evidence behind their work and they were empowered to use the evidence to advocate with the local ministries of health and others to support their programming. This also built capacity as partners learned the evidence through their involvement in the process. And by going through this process, stakeholders now recognize the importance of beginning with prioritization when they are beginning to design programs. So using the prioritization findings, Breakthrough Action and other partners were able to design more cohesive messaging, job aids, and materials. So the prioritization process can be adapted to outbreak responses or really the development of any SBC programs, ideally at the beginning, but also in other situations where too many behaviors are being promoted. This is a flexible process that highlights the importance of consensus building and aligning all stakeholders involved in a response to ensure harmonization. And the evidence review component is useful for prioritization and contextualization, even if we're reviewing evidence on diseases where we might already have quite a bit of evidence. It's good to update what we know, and an evidence review can also help highlight gaps and where programming can be developed to address these evidence gaps. So now to talk more about these research opportunities is my colleague, Kate.
Thank you, Jessie. I'm going to be talking a bit about how Breakthrough Research used research to inform SBC programming during a public health emergency response.
The SBC programmers and researchers use behavior change models as conceptual frameworks to understand and map pathways to change. The objective of SBC programming for Zika was to increase the use of the prioritized Zika prevention behaviors. This is a conceptual framework that shows the various determinants of behavior categorized into skills and knowledge, ideational factors, which have cognitive, emotional, and social components, which encompass risk perceptions, social norms, beliefs, self-efficacy, as well as environmental supports and constraints. Research can help play a role to understand these determinants of behavior. Some of this information can be collected in a KAP survey. The purpose of KAP surveys is to track changes in knowledge, attitudes, and practices over time in order to inform programming. There are different stages during which KAP surveys can be utilized in emergency responses. Before implementing a program, a KAP survey can be used for formative research to understand the behaviors and determinants to inform program design. Throughout the course of a program, KAP surveys can be used for monitoring to assess if there are any programmatic gaps or unintended consequences of the program. Towards the end of the program, KAP surveys can be used for evaluation to assess if the program is effective or to determine what needs to be adjusted in the future. The Breakthrough Research KAP survey was implemented in the later stage of the USAID Zika response to gain actionable insights to inform the response and facilitate program course correction. Our objectives were to collect information that was representative of the population and rigorously and appropriately measured in order to minimize bias. We also wanted to leverage the data for secondary analyses to explore associations with Zika prevention behaviors. A bit about our methodology. We conducted a household-level survey with men and women aged 18 to 49 in 4 countries: Honduras, El Salvador, Guatemala, and Dominican Republic. We conducted our survey in USAID program implementation areas only. This means we did not have a comparison group. We used the same survey questions across all 4 countries in order to get a snapshot of the region and provide standardized measures to inform the regional response. We used a multi-stage cluster random sampling strategy in order for our sample to be representative of the implementation areas. The survey was conducted from August to October of 2018, achieving a total sample size of 2,600 men and women, which is more or less 650 for each of the countries. We collected information on knowledge of arboviruses, transmission routes, prevention methods, and health consequences of arboviruses. For attitudes, we collected information on risk perceptions about arboviruses, feasibility of prevention behaviors, self-efficacy to do prevention behaviors, and social norms. We collected information on the use of arbovirus prevention behaviors. And lastly, we observed household water containers to check for use of lids and presence of mosquito larvae. We added observation to address a gap that we found in our prioritization process, which was the lack of evidence around whether use of lids was an effective way to prevent mosquito breeding in household containers. Adding this observational component to our KAP survey was a quick and easy way to obtain evidence around this question. Displayed are 5 of the 7 priority Zika prevention behaviors that resulted from the prioritization process that Jessie has just described. They include using repellents, eliminating stagnant water, using condoms, covering household water containers, and scrubbing household water containers to eliminate mosquito eggs. While we are interested in all these behaviors, we are focusing on self-reported scrubbing of household water containers for this analysis. So we wanted to understand the determinants of self-reported scrubbing of household water containers in the past 30 days. Many factors may affect this behavior, and we can use information from our KAP surveys for this secondary analysis. We use this data to examine associations of scrubbing and socio-demographic characteristics, knowledge and skills related to Zika and preventative behaviors, cognitive, emotional, and social ideational factors, and home visits in the last year. Home visits are a common SBC strategy for engaging individuals and households within communities using interpersonal communication. Many partners in the USAID Zika response used household visits as a strategy. Vector control and other technicians also commonly visited homes to carry out vector control activities, such as adding larvicides to water containers. By including home visits in our model, we can determine if receiving a home visit about Zika prevention was associated with a higher likelihood of carrying out an effective prevention behavior. For this analysis, we pooled the data from all 4 countries in order to identify the most important determinants across all settings. Using probit models, we controlled for socio-demographic characteristics such as age, sex, wealth, and education, and country. This slide shows the knowledge and ideational factors that we included in our model. For knowledge, we included awareness that scrubbing can effectively prevent Zika, Zika transmission routes, and knowledge that Zika is associated with birth defects. For ideational factors, we included perception that scrubbing is effective, feeling motivated to scrub, belief that most people in the community do something to prevent Zika, high or medium risk perception of arboviruses, and being an active member of a community group. To give you a sense of this outcome, we found that around 26% of respondents reported scrubbing their household water containers in the past 30 days. On this and the next slide, we present the results of our model. With regard to the socio-demographic characteristics, we did not find any significant associations with scrubbing. We found that knowledge of scrubbing as an effective Zika prevention behavior and knowledge that Zika can be transmitted either via mosquitoes or sexually were both associated with scrubbing, but knowledge that Zika is associated with birth defects is not. 4 of the 5 ideational factors were significantly associated with scrubbing, with risk perception as the one that was not. Self-reported motivation, perceived feasibility of the behavior, social norms about disease prevention, and participation in community groups had significant effects. We included home visit in our model as a 4-category variable based on the content of the last home visit received by households if they received one in the last year. So for people who received a home visit that only included interpersonal communication about Zika, we did not see a significant association with scrubbing. For those who received a home visit that only included direct actions by a vector control worker, such as eliminating mosquito breeding sites and applying larvicide to containers, we did not see a significant association with scrubbing. It was only for the combination of the 2, interpersonal communication providing information about Zika and the direct action together, that was significant. This is important because we are seeing that it is the combination of the 2 together, the information and encouragement that may come from interpersonal communication, and the potential skills and motivation that come with observing direct action that could be potentially effective for increasing practice of Zika prevention behaviors. Our key takeaways from the secondary analysis are that vector control and SBC programs should take advantage of home visits as a channel for interpersonal communication. And it's this combination of interpersonal communication and direct action during home visits that may be key for uptake of vector control behaviors, particularly in this case of cleaning water containers. We do not know the exact reasons for why this combination was important. It could be that this combination builds self-efficacy about general Zika prevention, or scrubbing in particularly, or that this combination increases the salience of the issue of Zika prevention so that it affects knowledge of consequences and therefore motivation to do the preventative behaviors. We also know that in this context, in addition to knowledge, both social norms around disease prevention and perceived effectiveness of the prevention behavior are important constructs to consider, and SBC programming seeking to maximize behavior change should target individual perceptions around these constructs. This type of analysis conducted during a public health response can provide the opportunity for implementers to operationalize recommendations about home visit content. Next, I'll be handing off to Martha, who will present some of the lessons learned from this work.
Thank you. Kate. So lastly, I will be talking about how we documented lessons learned in SBC programming to improve future responses, with a particular focus on the lessons learned around monitoring and research. So how did we document these lessons learned? The purpose of the documentation exercise was to capture successes, challenges, and gaps in the SBC technical area within the Zika response. And we did this in a number of ways, as you can see on your screen. We used an online survey of USAID implementing partners assessing the utilization of technical guidance documents that Jessie mentioned earlier. We also compared data collection instruments within the SBC community engagement technical area to assess comparability. And we conducted 77 stakeholder interviews in 6 countries, while also reviewing documentation that SBC and community engagement partners were producing as they closed their programs. A clearly identified challenge that we saw and that is common to public health emergency context in general is the urgency that exists when you're facing an epidemic or an outbreak of any sort. You have a shorter window for design, implementation, coordination, and a harmonization of efforts in general. So the process that Jessie described for behavior prioritization was widely considered a success within the Zika response. She described an evidence-based collaborative process that resulted in a more harmonized response and while still allowing for contextual adaptation, with the caveat that it was conducted on the 2nd year of implementation. So the recommendation for future public health emergencies is to carry out this prioritization process at the outset using the most robust evidence available and supplementing with technical expertise from other areas when sufficient evidence is not available. It's also worth mentioning, as Jessie did earlier, that even when facing epidemics of diseases that have been better studied than Zika, this process is extremely helpful in building consensus and can probably be conducted more quickly when the evidence is clearly present. The second lesson learned that I want to share today is around formative research. Again, in a public health emergency, partners are working in a time-constrained setting. Informative research is not prioritized due to the competing pressure to start implementing. The research methods chosen can also have an effect on the speed at which the research can lead to actionable insights. So when you don't conduct informative research or conduct it too late to inform your programs, this can lead to less optimal SBC program design. During the Zika response, formative research was conducted at some stage of the response and used for adaptation, but with what key partners considered were considerable delays and once programs were already on the ground. There were, however, a few clear successes of partners that quickly leveraged existing or ongoing research opportunities, such as, for example, an omnibus survey in one case, to quickly produce data at some level to inform programs. However, the recommendation for future public health emergencies is that more attention and higher priority needs to be placed on formative research, which should not be skipped at the beginning of the response. Rigorous and rapid methods can be incorporated into shorter timeframes to provide actionable insights from which to design SBC programs. The last lesson learned pertains to monitoring of SBC programs. With emerging infectious diseases, because the diseases are new and there's limited knowledge or experience, SBC indicators are not well established and not standardized. During the Zika response, it was considered a success that KAP surveys were conducted by several partners, and they were quite comprehensive, which led to a very information-rich environment. But again, there was insufficient coordination to establish a core set of SBC indicators that could be reliably compared across the response. So in future public health emergencies, we recommend that there be a clear mechanism to coordinate research, just as there are mechanisms for coordinating implementation of activities. An implementing partner whose mandate is to help coordinate research among partners could also help ensure that in an information-rich environment, research is quickly and effectively translated into programmatically actionable recommendations. So key takeaways from this lessons learned section: public health emergency responses require rapid research techniques, balancing speed and rigor. And as mentioned, a time-scarce environment requires stakeholders to engage in intensive coordination, not only for implementation of programs, but also for implementation of research to inform programs. So now for some conclusions on the role of research in a public health emergency context. SBC is a key technical area in public health emergency responses. From a historical point of view, looking back at the Ebola epidemic, it's considered that the Ebola epidemic failed when SBC approaches were not given the priority they needed. But once community norms that were causing transmission were addressed, things started to change. So SBC, as any other technical area, should be evidence-based, because SBC practitioners need to know that interventions are being as effective as possible. Our secondary data analysis also highlights that SBC is an integral part of a response program and should be cross-cutting technical area in order to achieve greatest effectiveness. In the example that Kate presented, interpersonal communication together with direct action or vector control direct action were most significantly associated with preventive behavior. Research can help inform SBC programming at all stages, and partners with SBC and monitoring, evaluation, and research expertise can support coordination to facilitate research utilization at all stages. So this concludes our presentation, and these are links. So for all of you who have registered, and I believe all of those who are online, you'll be receiving this presentation, and these are links that will take you directly to the resources that we've been citing, as well as a collection of other SBC-related materials for Zika. So you'll be able to link through to these resources. And I don't want to end the presentation without taking the opportunity to thank USAID and Zika implementing partners. As mentioned before, the behavioral prioritization process that Jessie described was a joint effort that was co-developed with Breakthrough Action, so special recognition to them. And we've had a great partnership between the two sister projects. Thirdly, I want to acknowledge my own team from Tulane School of Public Health and Tropical Medicine, the Department of Global Community Health and Behavioral Science that supported almost every aspect of this work. And lastly, our local research partners in the region, UNIVE in the Dominican Republic and TEPINET in Central America. So now I think we are ready to engage in Q&A. I'll just give you a minute to see if questions are rolling in. So we have one question here in the room. What do you think is the best way to ensure that the lessons learned throughout this process and from the different work that we've explored is applied next time around during the next outbreak? So maybe I will, should I start, Arianna, or do you want to? So a few thoughts around that. I think that one observation that we've made internally is that it seems like there's a lot of lessons learned, and after each emergency response, there seems to be many lessons learned and documentation. And when the next emergency hits, it's, you know, you have to hit the ground running. And so I think one of the things that we considered within the project is obviously dissemination, just as far and as widely as we can, disseminating these lessons learned, but also finding the spaces and opportunities to reflect deeply on these lessons learned, to be able to find ways in which they can be quickly operationalized when you are short on time and there's an emergency ahead of us. And I'm wondering if there are networks that we, if anybody in the audience knows of networks that are relevant that we should be reaching out to disseminate these lessons learned and also to engage in kind of reflection processes. We'd be happy to hear about that in the chat box if you have. So a second question here in the room, what were the biggest challenges you faced in disseminating the prioritized behaviors? Jessie, I'm not sure if you want to address that one. Do we have Jessie?
Hi. Challenges in disseminating our findings?
What were the biggest challenges you faced in disseminating the prioritized behaviors? So I'm interpreting that as once the prioritization ended and we had the behavior matrix, what were some of the challenges faced?
I think maybe one of our major challenges was that we, because of some reasons outside of our control, sort of started this process a little bit in the middle. So I think one of the biggest challenges was that some of the partners had already developed materials. And so we had to sort of do these course corrections in the middle of their programming, which I think was met with some frustration, but overall it really did help to align all of the programming. So I think ultimately it was an improvement and everyone recognized that, but initially receiving this feedback in the middle was challenging. I don't know if there's any others that.
Thank you, Jessie.
Yeah.
So I have a question. This is Lamini Pages speaking. I was just wondering about social behavior change in the context of environmental risk factors for Zika and other, if there's zoonotic transmission and that kind of, that kind of work. I was just wondering how that was taken into account and if you would be, kind of applying this work elsewhere or in another context, how environmental risk factors may also be taken in differently. I don't know if that's kind of a clear question, but kind of looking at social behavior change on a community level, and yeah, I was just wondering what the.
Are you asking how was that taken into account during the prioritization process?
Yeah, kind of just looking at the behaviors that would be most, sorry, I'm trying to figure out how to frame the question better. I guess, yeah, in the prioritization process.
I'm having trouble capturing that. Right. So how would you apply the prioritization process for a different disease in a different context? Is that the?
No, I guess. Sorry, I think my question just might be unclear. I was just wondering about how you, when you're choosing these behaviors to kind of encourage or have communities implement, how does kind of environmental risk apply? How do you take that into account? When, for example, sorry.
You have some examples of environmental risk factors.
Yeah, so for example, if there's communities that have large standing bodies of water where there's, higher rates of of, mosquito-borne disease being able to affect populations, and there are community-level behavior change that could, I guess that's
I see what you mean. So not at an individual level, but
right.
Collective.
Yeah, whether it's like community planning or
yeah.
that kind of.
So that, do you want to respond? Or?
Sure. So that, that is definitely something that we dealt with in the Zika response, because a lot of the behaviors were collective, community level behaviors, and even if an individual performed a behavior, it was not necessarily enough. In the cases in which, for example, standing water is a good one. In the cases in which your neighbor's behavior affects the overall outcome. So that is, from the programmatic point of view, that requires interventions such as just community engagement. So what was done was, community cleanup events, encouraging communities to kind of take pride in the sort of lack of breeding sites in their communities and that sort of thing. In terms of prioritizing the behaviors, some of the behaviors that we had were definitely collective ones, and they were, performed by an individual or the community. So we had removing standing water in your household, but then also the community level. And the way that was implemented at the collective community level was through those community events and cleanup campaigns.
I'm in the room. This is Kim Hoffman, Breakthrough Research. I'm just wondering, when you were talking about the suggestion of finding networks and things, I know that the core group had a disaster preparedness group monthly call. I joined that once. I'm not sure if it's still ongoing, but the idea of having, whether it's biannual or quarterly, whatever the modality is, and having the key stakeholders, USAID, UNICEF, implementing partners together, just as a check-in, sort of like an emergency response surveillance meeting. Yeah, preparedness call, so that we're now seeing this odd flu coming out of China, and so we're ahead of the game in terms of being able to keep a pulse on what's happening globally, and then be prepared to respond, and have those resources in place more rapidly, instead of seeing it by surprise, like the floods in Mozambique or other disasters.
Okay, so I think we're ready to wrap up this webinar. Thank you very much for all who joined online, and we will be sending out a link to the slide deck so that you can access also the resources that we have on there. So you can look forward to that email pretty soon. And thank you all in the room, and happy Thursday.